Good morning, everybody. Today I will be talking on congenital nystagmus, and at the outset, I would like to thank Dr. Samir Patra for giving me this opportunity to speak on congenital nystagmus. Now, first and foremost, when we move ahead with talking about nystagmus, what exactly is nystagmus? So, nystagmus is actually defined as rhythmic oscillations. So, it is not unwanted movements. They are purely rhythmic oscillations of eyes, and they are normally always involuntary. They can be voluntary in some of the cases. Now, what happens is that we would normally ask, what exactly is the defect in nystagmus? Why does nystagmus occur? So nystagmus basically occurs because there is a disturbed feedback to the gaze centers in the brainstem. And this interferes with the control of our fixation mechanism. And what is fixation mechanism? Basically, fixation is not something which is a once in a time process. Fixation is the visual system's ability to detect retinal image drift. So whenever we are looking at an object, basically what we are doing is we are trying to fix on that particular object, and our face movements or our eyes, there can be some image drift. So it is visual system's ability to detect that retinal image may drift, and these unwanted saccades have to be suppressed in time to prevent any retinal image drift. So what is essentially happening in a simple term, what is essentially happening is that the eye has drifted like this, and once there is a retinal image drift, there is a corrective movement. And then again it is drifting, and there is a corrective movement. Again it is drifting, and there's a corrective movement. So visual systems inability to check this particular feedback mechanism. The feedback mechanism is through the proprioceptive receptors, which are there at the muscle insertion, horizontal rectus, vertical rectus muscle insertions. And these muscle insertions basically work like a GPS and send biofeedback to the brainstem to control the image drift which may occur and to prevent any unwanted saccade. We all know that the basic difference between a saccade and a pursuit movement is that once a saccade is initiated, it will end, and only then you can bring the eye back. So to prevent any unwanted saccade, what happens is that there should be a feedback to the brainstem, and that will stop this unwanted saccade. So nystagmus, the common question that nystagmus, why does nystagmus occur? The answer is that there is a problem in the feedback of the gaze centers at the level of brain. Now, how do we, there has to be a system as to how you have to write about nystagmus. There has to be a way that if I am saying that this is a horizontal nystagmus, this is a fast phase is on the right side, there should be a difference. There should not be any difference between the two people. Now, if you see this child, the child is having nystagmus and she is beating. She has a pendular nystagmus. And there is a small variable component, and there is an occasional jerk nystagmus. When she is looking towards the left, it is beating towards the left. So this is how you have to write. You have to find out the fast phase, and then you have to write left beating nystagmus, which essentially would mean that the fast phase is towards left, which means the slow phase is on the other side. And then you can talk about whether it is jerk nystagmus, which means that one of the nystagmus movements is fast and there's a corrective slow phase. So that is a jerk nystagmus. And if the amplitude is equal on both the sides, then it is a pendular nystagmus. Now, this could be fine, which means it has a very small amplitude. It could be moderate, or it could be really large amplitude where the eye is moving from right to left at a speed, which could be slow or fast. Now, what is null zone? Null zone is a unique place where the intensity of nystagmus completely reduces. Now, this null zone has to be differentiated from neutral zone, which essentially means that patient who was beating towards left, when he moves the eyes and starts looking on the right side, he starts beating towards right. So this change in phase from left beating to right beating occurs at neutral zone. Now, null zone can occur at any place, and it is basically a selective zone It is around 4 to 5 degrees. It's a small area. So this particular area, the nystagmus intensity is minimal and absent, and null zone is responsible for the face turn, chin elevation, chin depression in patients. Now, as per the waveforms on electronystagmogram, and we will talk about it later, the waveforms which are slow phases, the slow phases can be accelerating or decelerating, which means that the velocity of this particular slow form is gradually increasing or it is gradually decreasing and coming to an end, from where the fast phase will take over. So depending on whether it is accelerating or decelerating, there is a difference in management, there's a difference in morphology, there's a difference in what the patient would have. So broadly, we can classify nystagmus on the basis of velocity waveforms of slow phase also. Yeah. So what is one of the most important point here that we have to understand is the difference between congenital and acquired nystagmus. So how do we find out? So there are multiple ways to find out. It is very important because if there is acquired nystagmus, neuroimaging is mandatory. So if the patient says that there is oscillopsia, has developed nystagmus only recently, and this was not there since childhood, we should think of doing a neuroimaging immediately. Now, the congenital nystagmus, these are all the points of congenital nystagmus. The congenital nystagmus can be sensory or motor. So there is an underlying defect in the visual system ability itself. Like there is a detachment or there is a dystrophy, there is ROP, there is problem with optic nerve, there is optic atrophy, there is at the level of brain, there is static encephalopathy or progressive encephalopathy. Congenital nystagmus would normally be bilateral. The amplitude will be equal. It will be predominantly in a single plane. Like if it is in the horizontal plane or vertical plane, it will be predominantly in a single plane. Oscillopsia, since it is there since birth, patients normally do not complain of oscillopsia in congenital nystagmus. It could be of variable intensity, could be jerk or pendular. There can be a null or neutral zone in congenital nystagmus. There can be a latent component, which means that, whenever you cover the eye, whenever you cover one of the eyes, the eye which is not under cover has a increased amplitude and velocity of nystagmus, and it starts beating towards the fixing eye. Now, congenital nystagmus would normally be absent in sleep. That can be associated head nodding, head movements, and it would dampen with convergence. So if you tell the patient to converge or if you give a accommodative target, normally congenital nystagmus would dampen. So these are some of the points where you can easily find out that, there is a difference between congenital and acquired nystagmus. Now, congenital nystagmus can be broadly divided. It has been broadly divided by Kogan way back in 50s and 60s into congenital motor nystagmus and congenital sensory nystagmus. And the division was very arbitrary. The division was that in congenital motor nystagmus, there is essentially the motor component of nystagmus which is there, and there is no underlying sensory pathology. Now, we know that way back in 60s, we really did not have high-tech gadgetries to find out those subtle sensory problems which may still be there. But nevertheless, this was a good classification till the time it served. And now we have a different classification. So there are broadly two kind of classification, which is like infantile nystagmus syndrome, idiopathic nystagmus versus fusion maldevelopment nystagmus. Now, this would be normally a manifest nystagmus, and fusion maldevelopment nystagmus would have strabismus, would have latent nystagmus. So these are all associated things, but broad classification now is idiopathic nystagmus syndrome, infantile nystagmus syndrome versus fusion maldevelopment nystagmus. Now, clinical features in motor or idiopathic or infantile nystagmus syndrome is amblyopia and astigmatism would be there. Normally, they would have a with the rule astigmatism, no oscillopsia. There can be some stereoacuity. Strabismus would not be very common, but it may be present. There can be a head posture mainly because of null zone, because there is a null zone. So there is a head posture, and there can be head shaking also. So this is one of the cases. I'm just trying to show some of the cases. You can see that patient has a face turn to right with a little bit of chin elevation. Patient is turning his head towards right. Patient is having horizontal conjugate nystagmus, null zone on the levo version. It was jerk nystagmus, and this particular nystagmus type would have exponentially increasing velocity waveforms. So if you do a ENG or VNG in these particular patients, this waveform, the slow phase, will have an increasing velocity waveforms. We will see ENG later. The visual acuity and fixation is slightly better. The fovation period is slightly better in infantile nystagmus syndrome compared to fusion maldevelopment nystagmus, where you will see latent nystagmus is present. Fast phase, whenever there is a latent nystagmus, the fast phase is toward the side of the fixing eye or the uncovered eye. There is a defect in cortical motion processing that results from lack of development of binocular vision. So what it means is that the maldevelopment of fusion is primary, and that is causing a defect in cortical motion processing. This imbalance in the subcortical optokinetic system is actually secondary to original cortical motion detector, which is secondary to the lack of development of binocular vision at very early age or at very early time. So this nystagmus will have an associated strabismus, will have exponentially decreasing velocity waveforms, will have manifest latent or latent nystagmus, which will be present. So whenever you see an ENG of these particular patient, you will see that the slow phase will have a decreasing, exponentially decreasing velocity waveforms. So this is one of the patient. You can see whenever you cover the eye, you will see that there will be a latent nystagmus which will be present. You can see there's a very fine nystagmus, but you can easily see that there is a fusion maldevelopment nystagmus in this particular case. See, whenever you cover the eye, there's a subtle movement which can be caught. Now we move on to talk about what could be the reasons for nystagmus. So obviously the basic reasons could be that there are media opacities like cataract or corneal problems like ROP or albinism, macular scars, rod cone dystrophy, optic atrophy. Then there can be neurologically problem, but with visual sensory system is normal. Those are the causes for idiopathic motor or primary nystagmus, whatever way we want to define it. Then there can be neurologically abnormal. Neurologically abnormal means that there is actually a problem at the level of brain and not at the level of eye. But the problem is static, and it is basically a static encephalopathy, like children of NHBI, neonatal hypoxic brain injury, or could be Joubert syndrome, where there is a hypoplasia of Vermis. And there can be neurologically abnormal with progressive neurodegenerative or metabolic diseases. So multiple causes, multiple reasons, both at the level of eye and at the level of brain can be there as the etiopathogenesis of congenital nystagmus. Another important variety is nystagmus blockage syndrome, which we have to understand before we really talk about before we complete the discussion of congenital nystagmus. This is different from CNCS syndrome, where the primary pathology is infantile esotropia and nystagmus. Here in nystagmus blockage syndrome, it is basically the primary pathology is nystagmus, and to block the nystagmus, patient is converging or esotropia is developing. There will be commonly will have manifest nystagmus and not really have latent nystagmus. And the waveforms, when you see the waveforms of these patients, they do show accelerating slow phases. So typically they would be typically like congenital motor or infant idiopathic nystagmus syndrome. Esotropia is present without nystagmus. When the patient is trying to block the nystagmus, there is esotropia on visual attention and orthotropia with nystagmus on visual inattention. So whenever patient is trying to reduce the nystagmus, dampen the nystagmus, or trying to block the nystagmus, there is esotropia. The treatment of CNCS syndrome and nystagmus blockage syndrome are very, very similar, both have medial rectus recession with Farden, but the underlying pathology, the understanding is slightly different. So let us see a small couple of slides on what is ENG, because normally whenever we talk about congenital nystagmus and somebody talks about electronystagmogram, we sort of feel that, this is too complicated. So we should have a small understanding of something on ENG or video nystagmography or electronystagmography. This is not really very difficult. Let me take you through it. So basically what we have here is that we know that cornea has a positive charge, and basically the posterior part of the eye has a negative charge. So whenever patient tries to look on the side of this particular electrode, there will be a there will be a positive waveform. This is the neutral waveform. And whenever the patient looks on this side, there will be a negative waveform. So basically what we are trying to see is whatever is the, ocular corneoretinal potential, we are trying to measure it with the help of movements of the eye. Whenever patient looks on the right side, looks on the left side, there's a difference in the corneoretinal potential, and that is what we are tapping with the help of electrodes. Now, this is very easy to understand. So by convention, right means up and left means down. So if the eye is coming, like if I see this is the slow phase, slowly building up, taking its own time, and this is the quick fast phase. So if it is coming down, it means it is fast phase is towards the left. This is the entire duration of one cycle of nystagmus. There is a slow phase, fast phase, slow phase, fast phase. And these are the typical, electrode positions. On the right, on the left, there is a neutral. And if you want to measure up and down, one on the up, one on the down. So if this is the fovea, typically with convection, up means right and down means left. So this nystagmus is moving towards right and going down, going up, going down. This is a left beating nystagmus. This is a left beating nystagmus because you can see that fast phase is moving from up to down. And this is actually an accelerating waveform. You can see that the velocity here is slower and gradually it increases. If this is the linear velocity, this is what will happen. This is the linear velocity. The velocity will remain constant. So if there is a straight line, it is linear velocity. There are neither acceleration nor deceleration. This is decelerating velocity. So these terminologies are the old terminologies. Congenital motor nystagmus, manifest latent nystagmus. So this is the slow phase beating towards left. Now, if you see these, this is left beating, going down, again going up, going down. This is accelerating, left beating. This is accelerating, right beating, because it is going from up to down to up. So this is accelerating, right beating, accelerating, left beating. This is, decelerating, left beating, decelerating, right beating. And you can see linear. These are straight lines. Right beating, left beating, the waveform is very, very easy. So it is not at all difficult. So we should not get confused whenever we talk about, electronystagmogram or video nystagmogram. They're very easy to understand. So now we come back to what are the goals of management. So goals of management, typically, everything in the eye is related with to increase the visual acuity. So the goals of nystagmus management is reduction of intensity of nystagmus, decreasing slow phase velocities, increasing foveation period. Foveation period is the time for which the image is on the fovea. So that is increasing foveation period, and use of abnormal head posture, again, to increase the visual acuity. So the goal of management revolves in and around the increase in visual acuity. Non-surgical management of nystagmus, first and foremost, is to do cycloplegic refraction and to correct astigmatism. Most of in our work, which we did in 2006, we found that bulk of the patients will have with the rule astigmatism, and if you correct the astigmatism and anisometropia, there will be some improvement. So you have to do a cycloplegic refraction, give the glasses, and if you feel that, brinzolamide eye drop, which is a different topic, but what brinzolamide eye drop is doing is it is improving the proprioceptive receptors. So in my own personal view, around 8 to 10%, sometimes, some of the patients, if you give them brinzolamide eye drops, their nystagmus does improve. The numbers are very small, so you should choose your patients very, very wisely. So prisms can induce either convergence. We know that convergence dampens congenital nystagmus. So you can give base out prisms which can stimulate convergence, and you can decrease the nystagmus. Not very practical, because when you give prisms, he has to constantly accommodate, constantly use the fusional convergence, and that may create some headache or some brow ache. Face turn, you can give prisms. Again, face turn, if it is very small face turn, like around 8 to 10 prisms, you can easily use prisms. The strategy is that it has to be oriented with apex towards the direction of the preferred gaze and base in the direction of the head turn. So if patient is if patient's null zone is on the left, the apex of the prism would be left in both the eyes and base would be towards the face turn. So if you have null zone in levo version, the face turn would be towards right. So the base of the prism would be towards right and apex would be towards the levo version, toward the face turn. Now, I don't have much experience with contact lens, but they do say that contact lens does dampen nystagmus and improve visual acuity, though I don't really prescribe contact lenses. Yes, I do give brinzolamide and acetazolamide because it is supposed to improve the cortical motion processing, not by working at the level of brain, but actually by working at the level of proprioceptive receptors. The biofeedback increases. That is what is the theory for brinzolamide. And some patients do improve. Baclofen and carbazepine can reduce nystagmus, mainly for acquired nystagmus because they have oscillopsia, and not really for congenital nystagmus. And botulinum toxin, Botox can be given, but the problem is that whenever you are giving a direct muscle injection, the effect would last from 6 to 8 weeks only, and it would keep coming back. So that brings us to the surgical management of nystagmus, and most of the nystagmus patients can be helped only when there is a null point, and basically the principle is to move the null point to the primary position. And the question is how to accurately measure the null point. And I think this is a very wonderful device which you can use to accurately measure head tilt, chin depression, chin elevation, and face turn. All the three parameters can be measured with the help of cervical range of ocular motility. It's basically an orthopedic instrument, but it is a wonderful instrument which you can use to measure the face turn, chin depression. You can see that, with the help of these dials, you can accurately measure in all the three XY axis, and all the three axes you can measure whether there is a face turn associated with chin elevation and head tilt. So we have to measure patient on several visits to be sure that head posture and magnitude is consistent, and not that there is a periodic alternating nystagmus and the face turn is changing. We have to recheck the patient several times during examination also, and to ask the patients and parents that there is only one null and there are no periodic alternations, and we should examine them both at near and distance. And there can be some patients who have different null position for near and different null position for distance. So that is to be taken care of whenever you see them. And then we move on to the patterns, how to manage congenital motor nystagmus. So Castenbaum form, which is the conjugate form, which means that both the eyes move towards the same point, either right or left. So null zone is on the right or on the left in the same field. And then there is a disconjugate form, which is also known as CNCF form, where null zone are located in adduction and both the eyes are moving towards each other, where the surgical management would be to weaken both the medial rectus, and if it is very large, you can go ahead and do a Farden surgery also. So for Castenbaum form, which is the conjugate form, in absence of strabismus and in presence of strabismus. So if there is an absence of strabismus for 15 degree up to 20 degrees, you can use this straight flush, which has been suggested by Marshall Parks. And for 20 degrees, you can do 5, 6, 7, and 8. If the face turn is towards right and the null zone is towards the left, you can do this. And if it is more than 20 degrees, you can keep on adding the numbers depending on the amount of face turn. Now, in presence of strabismus, you have to first and foremost decide which is the preferred eye for fixation. Next, you calculate what is the dosage of surgery for that eye to bring into the null zone. Whatever strabismus is remaining in the fellow eye has to be tackled. So if we see in this particular case, if this particular eye is the fixing eye, we have to fix it for nystagmus, and whatever strabismus remains has to be treated in the non-fixing eye. So this is the difference. When you have an absence of strabismus, you can just straight flush. And if there is a presence of strabismus, you have to first see the fixing eye and then move towards management appropriately. So in presence of strabismus, we have to determine the preferred eye of fixation. As we discussed, we have to calculate the appropriate dosage for surgery to center it into the null zone. And then we have to calculate appropriate dosage on the fellow eye to center the null zone and adjust for tropia. Now for CNCR form, as I said, you can see this particular patient. This particular patient has esotropia, and to center each eye's null position, we have to correct esotropia. And so we do maximum MR recession with or without Fadden, depending on how large the esotropia is. So in chin up posture, what you are going to do, the null zone is in the down gaze. So basically, if the null zone is in the down gaze, you have to elevate the eyes in such a way that null zone which is in down gaze comes in the primary position. So you will be recessing inferior rectus of both the eyes, and you can resect superior rectus of both the eyes. And for chin down, you will do other way around. The null zone is an up position, and you have to bring the eyes down so that null zone, which is in the up gaze, comes in the primary position. So you will recess the superior rectus and resect the inferior rectus depending on how much is the null zone. Now, if there is, if this is one of the patient where you can see it was a complicated patient. Basically, patient, what he had was, he had, he had a head tilt to the right with a face turn to the right. So you have to manage the face turn. Along with that, you have to look for the torsion and chin elevation. In this particular patient, we could not manage chin elevation, but we could manage his horizontal and head tilt, which was prominent. This is after 1 month. He has got a small chin elevation, but because we were managing his torsion with the help of horizontal muscles, we could not supraplace or infraplace them. So this was a very good result where we could manage his head tilt also. So you can manage the head tilt as well as horizontal gaze positions together. So in summary, you have to record the pattern type and plane so that whenever the patient comes back, or if the patient goes to another associate or another colleague of yours, they know what has already been done. They have to do refraction. Fundus documentation is a must, because you have to find out what exactly is the idiopathogenesis, whether it is sensory, whether there is a cause for causes in the eye, or it is at the level of brain, whether it is congenital or acquired. Have to give cycloplegic refraction. We can start brinzolamide eye drops and then wait for 3 weeks and see if patient says that there's a benefit, you can continue it, or you can move on to surgery if there is a face turn. Remember, if there is no face turn, then it would be very difficult, and you will have to just give the glasses and tell the patient that, this is the max that can be done. So thank you so much for the invitation. Thank you.